This conference will now be recorded.
Okay, can we start, please? This is your first OSCE station.
Okay, so I would begin by, so the first question is that can I start trying for a pregnancy doctor? So I would begin by
Please.
introducing myself. So my name is Jill Mitchell. I'm one of the obstetric doctors, and it's lovely to meet you, Mrs. Harvey. And I would begin just by confirming the patient's name and demographics, and I would just talk to her a little bit about her history. So she's 26 years old, and I'd ask her, is this her first pregnancy? And I see you had a renal transplant, and do you mind me asking why you had a renal transplant? And the reason I'd ask this is because, of course, if it was a congenital condition such as polycystic kidney disease, then that would have implications for the pregnancy. And I would ask, when did you have the renal transplant? What type of transplant is it? How is the graft function? What medicines are you on? Are you on tacrolimus? Are you on cyclosporin? Have you had any complications with it? Who do you attend for the transplant? Are you regular with your attendance? Have you had any issues since? And then in terms of, do you have any other medical conditions at all? And because if it was an autoimmune condition, she might have other autoimmune conditions. Did she ever have surgery apart from the transplant? Is she allergic to medicines? Does she take any regular medicines? Any family history? And does she smoke? Does she drink alcohol? What does she do for a living? Does she have good support at home? I would assure her that so I tell her the purpose of the meeting is to talk about plan her future pregnancy. I tell her that her graft function does seem to be quite good, so that would imply that she should have a good outcome in the pregnancy. But of course, there are going to be risks, especially the fact that her creatinine is already mildly elevated. Those risks are, the most important risk is that she's a high risk for high blood pressure issues in pregnancy, I tell her. So, and then I'd elaborate that those include high blood pressure in pregnancy and also preeclampsia, which is a condition that you get high blood pressure as well as protein in the urine, and then going on for that can affect your liver in something called HELLP syndrome. And I tell her that she is at increased risk of preterm labour, of fetal growth restriction, and of abruption, which is the placenta separating from the womb. I'd say that it is safe to have a baby. However, we would monitor you very closely. We'd see you in a multidisciplinary led clinic, so with a high risk obstetrician who's used to dealing with kidney transplant patients, as well as with a renal consultant that we would advise, and that she just has to have regular folic acid unless she's on antifolate, and then that she'd have an early booking scan, that she'd have an anatomy scan at 20 to 22 weeks, and that she'd have fetal growth surveillance from 26 weeks. I'd assure her that there is no reason that she'd have to have a cesarean section as long as the baby is well. But I tell her that we will be testing her blood pressure and urine specifically at every antenatal clinic, and that, as I said, she's going to be in a multidisciplinary led team, so she's going to be very linked in with the renal service at all times as well, to check her graft function to make sure that she's not having any compromise, but that in general pregnancy is an immunocompromised state, so those with that it usually doesn't affect graft function. And then in the postnatal period, we'd advise her to breastfeed, and that it shouldn't have any implications for her baby, provided the baby wasn't born preterm or born small. So then I can see that the next question, question B, is how will your management of this pregnancy differ from a normal pregnancy? So I think I've answered that in question A, that it will be enough. Yeah, so I'll continue on. So then C is Mrs. Harvey is 23 plus 3 weeks pregnant and was admitted to the ward of preeclampsia 2 weeks ago. You're the resident on duty and have been called by the midwives, feeding well done. Okay. So I would attend the patient as soon as I was called, because I would be aware that this is a high risk patient. I would take a focus history. I'm already aware of the patient's background history, but I'd want to know, when was she diagnosed with preeclampsia? What are her blood pressures like? What is her PCR? What are her liver function tests, platelets, and urinary, urate, and LDH levels? I'd want to know what medication she's on for the preeclampsia. I'd want to know how she's feeling, and specifically in terms of, does she have a headache, any blurring of vision? I can see from the text that she has abdominal pain. I'd want to see specifically, could this be liver capsule pain? In which case it would be right upper quadrant or epigastric pain. I would check her reflexes to see if she have hyperreflexia. I'd check for a sustained clonus, and then I would ask to see, does she have any increased edema, or does she have any jerking motions? And of course, I'd want to know what her most recent blood pressure. I'd want the nurse with me to do a full set of vitals for the patient as well. And specifically, I'd want to know what her blood pressure is. So in terms of please manage, so my #1 differential diagnosis for a lady with renal transplant, known preeclampsia, and now developing feeling unwell and abdominal pain is evolving HELLP syndrome. So this is an obstetric crisis. So of course I would, as I said, do the vitals and send off the bloods and with my clinical history and examination. But if my differential diagnosis is confirmed, then I would want to call senior help. I would check a Doppler ultrasound to check for fetal heart, but I wouldn't be doing a CTG at 23 and 3 weeks. I would manage the blood pressure. So if she's able, depending on what the blood pressure is, and if she's able to tolerate oral intake, you could either give her 200 labetalol or else 50 milligrams of labetalol as a stat IV infusion. And then you can give stat IV up to 200 milligrams. And then at that stage, you commence a labetalol infusion of 20 milligrams per hour, increasing up to 160 milligrams per hour as needed. And if you felt that if you felt she was at risk of a clamptic seizure, which you would be in this case, then I would start magnesium sulfate. So, and of course, I'd have 2 IV cannulas inserted and the blood sent, anesthetics informed, and the consultant anaesthetist and obstetrician ideally present. In terms of magnesium sulfate, I'd give the bolus dose first, which is 4 grams over 10 to 20 minutes, and then I would, over 10 to 20 minutes, and then I would commence her on the infusion rate, which is 1 gram per hour. I would move her to a HDU setting. I would want one-to-one nursing care in a dimly lit room. I'd want continuous vital signs, and I'd want, she's at risk of a VTE, so TED stockings on, and of course the ultimate treatment for this is going to be delivery. So if this does become severe uncontrolled preeclampsia with evolving HELLP syndrome, then timely delivery is necessary. Always my differential diagnosis in HELLP syndrome is going to be acute fatty liver pregnancy, hemolytic uremic syndrome, and thrombocytopenic purpura. So I would have those in the back of my head as well and be out ruling them as I go along. And then I guess no matter what, after this, you'd want to debrief the patient very well, debrief the staff very well, debrief the partners. You'd want the patient linked in with renal and to check the graft function. You would want the patient linked in with the consultant. What I didn't mention was that, of course, someone with severe preeclampsia at 23 and 3, I'd want an ultrasound scan of the baby to check the fetal weight and fetal viability. Of course, you would only do this after you stabilize the mother, because you have to stabilize the mother before you look at the child. But I would check the fetal viability, check the fetal weight, and if the baby was over 500 grams, I would get a neonatal consultation to talk to the mother about what to expect. And as I said, in the follow-up period, then I would have a consulting review by the mother, plus minus bereavement if the child passed away. I would link the mother in with renal, of course, as well for ongoing care. And also I would consider thrombophilia screening, and so acquired and inherited thrombophilia screening. And what I didn't mention, actually, sorry, in question A, which is extremely important, is that of course this mother should have been started on 75 milligrams of aspirin to prevent against preeclampsia, and I would ensure that she continued that the whole way through. And what I would have done, the preconceptual counselling as well as the postnatal counselling, is ensure that any other risk factors such as smoking are optimised.
Okay. If I ask you that, which is the most important predictor of fetal survival? What will be your answer? Baby's neonatal survival. Yes.
Fetal weight and gestational age.
Yeah.
Perfect.
So we should put, gestational age should be first, followed by the fetal weight. Okay, like that. Okay. Because maybe the baby's IUGR or some problem is there. So that's why we will talk about the fetal weight first, gestational age first. Okay. Thank you very much. So let's go to the second station. Let's put all the info on one page. Let me slide it up for you. This is your second patient, and this is the scenario. So you can take 2 minutes and then we can talk about this patient. Yes. The results and the ultrasound result, everything is here. So is it okay if you want me to enlarge it?
No, it's fine.
Okay, that's fine.
Okay, I can start.
Okay,
So
welcome. You can start, please. Yeah.
first of all, I would take an appropriate history. So I would introduce myself as Jill Mitchell, one of the obstetric doctors, and I would confirm her name and how she'd like to be addressed. So I'd ask her a bit to tell me about why she was brought here today. So I'd want to know about the bleeding, and specifically how long has it been going on for? Was it heavy? Was it associated with pain? Was there any other symptoms? I'd want to know, when did her period stop? Was she taking hormone replacement therapy? Has she ever been on tamoxifen? I would have a quick look at her BMI. I would ask before her period stopped, were her periods normal or were they irregular? Were they very heavy, painful? When did she get her first period? Was it very early or late? And then, were her smear tests normal? Then, did she have any other symptoms? Did she have any weight loss, poor appetite, bloating, change in bowel habits, night sweats? Did she, and then, does she have any other medical problems? Go to a doctor for any reason? Has she ever had surgery at all? And then specifically in medical problems, I'd want to know any history of breast cancer, or bowel cancer. And then, in terms of, she have any allergies to any medicines? Does she take any medicines? And specifically, I'd want to know about hormone replacement therapy, tamoxifen, and anastrozole. Does she smoke? What does she do for a living? Who is she at home with? Does she have good support at home? In terms of family history, is there any family history of, specifically, are we looking for clues of Lynch syndrome or hereditary non-polyposis colorectal cancer? So things like people getting bowel cancer in the past, breast cancer in the past, womb cancer in the past. And then I'd want to do a review of symptoms and then see, what is she concerned about? Does she have any worries? And then I would, in terms of examining her, so I would, and then so I would look at, first of all, general appearance. Does she have a high BMI? Does she look like a smoker? Does she look healthy in herself and well? And then I'm doing an abdominal examination, feel for any masses. I do it by manual examination to feel the bulk of the uterus, and is it fixed or free? Is it anteverted or retroverted? Is there any adnexal masses? And then I do a speculum examination to look at the cervix. So then I would, in terms of examinations, I would, depending on her risk factors, I would do a transvaginal ultrasound scan and papal biopsy, or else go straight to hysteroscopy and biopsy, depending on the risk factors. So then, going to part 2 of this, is that the patient presents a week later for the results of the investigations. Okay, so I would again welcome her into the room and sit her down, and ask how she is, ask would you like to bring anyone with her, and then talk about the events again leading up to what brought her here, and say that that I ordered you a pelvic ultrasound scan, and what do you know so far and what do you think is happening so far. And I'd ask, is it okay if I continue? And I'd say that the reason that I ordered the pelvic ultrasound scan was because anytime that you're having bleeding after your menopause, we have to make sure that there's no risk of abnormal cells. And I'd say particularly we're looking for cancer or any changes that may lead to cancer. I'd say that in the ultrasound scan that I said there is some thickening of the lining of the womb. So I'd say that the most important what we should do now, if it's okay with you, is bring you in and do a camera test to have a look at the lining of the womb and take an appropriate biopsy. I'd assure her that she did the right thing by coming in with heavy bleeding, that even if this does turn out to be that about 10% of the time postmenopausal bleeding does turn out to be endometrial cancer, but that it's usually a very treatable cancer because you came in early and because you got this treated. So there is a lot we can do for you, but this is the next step. And I'd ask her, I tell her, I'm sorry, I know this is a bit of a shock that I'm telling you this about the thickening, but I just want to be completely honest with you. And I'd ask, is there any questions that she might have, or anything I can do for her. Then I tell her I go through the risks of hysteroscopy and D&C with her. So pain, bleeding, infection, perforation, damage to local structures, procedure failure, need for further treatment, and the risk of general anaesthetic, or unless if you're doing it as an outpatient. And then I would arrange for her to come back in at that stage. I would send her to the anaesthetic clinic for a pre-op assessment if needed as well. And I give her patient information leaflet. So then I'm seeing her back, and it came back that it was grade 2 endometrial carcinoma. Okay, so first of all, I guess I'd bring the patient back. I would, again, in the same manner, explain about the diagnosis and answer any questions that the patient might have. I would refer her to the cancer centre, to the liaison cancer nurse, to the MDT, and I would organise some more scans for her. So specifically, I'd organise an MRI scan and a CT tap. I would also ask if the patient had any more questions, and of course, I would ask her, did she want to have anyone with her before I gave her the news? And then I would give the patient an information leaflet, bring the patient back to see me as well, just to talk through the results and of any of the scans that I organised, and tell the patient that she'll be getting an appointment from the oncology team. And I'd explain to her that the MDT is a group of experts that come together, such as nurses, physiotherapists, occupational therapists, cancer specialists, oncologists and gynecologists, to best plan the best possible treatment for her.
Yeah. Okay.
And give her patient information leaflet and link her on to support teams as well.
Yeah, that's great. Let's go to the third station. There it is. Once you finish reading it, then we'll go to the next page.
Okay.
Okay, let's go to the next page. Shall we go to the previous paragraph?
Yes,
That you
please.
can see that in what circumstances you have carried out this procedure.
Yes, please. Okay, I can start now if you like.
Okay, please start.
Okay, so when I'm in the room, so I would introduce myself to the patient and tell her who I am and what my reason for being there is. And I always tell her that I'm quickly going to get a handover from the nurse, if that's okay. So with the nurse, I'd want her to tell me, of course, I'd hope you already know this, but the antenatal care for Mrs. CK, is she a primate? How many weeks gestation is she? Is this an induced labour or a spontaneous labour? Did she have any complications, such as diabetes, gestational diabetes, preeclampsia, food growth restriction, large related age, any problems during the pregnancy? And as I said, is this induced or is it spontaneous? I want to know, was the labour induced? Was the labour augmented, or did she progress to 10 centimeters dilated by herself? Was she given an hour of passive descent? And then I'd ask, without being obvious, I'd ask, is the maternal effort adequate, does she think? And then I would, and then I'd want to know, is just what kind of analgesia does she have? Does she have an epidural or not? And also, so then I would introduce myself again to Miss CK. I would tell her that, that I would have a good look at CTG to see what they mean by abnormal. Is it pathological or is it suspicious? So I look at the baseline and the variability. I check for accelerations. I look at the decelerations and see if I could grade them into early, variable, or late. Then I would explain to Mrs. CK that, she's doing great, but she's been pushing for 2 hours now. And also it looks that we're looking at the baby's heart rate monitor, it looks like the baby's starting to give out. So that for those two reasons, the fact that she's been pushing for 2 hours and the baby still hasn't come, so the baby's starting to get tired, and I'd imagine so is she, and that now there's some abnormalities in the CTG, that it would probably be better if I give her a hand. And I explained that by giving her a hand, I mean either using a suction cup or else a forceps, which are like 2 spoons, and that I still will need her to push during this, but this is just so I can help guide the baby's head out. I'd get her explicit consent for this and also for an episiotomy, and then I would proceed. So I proceed by examining the abdomen first to check for fetal presentation and to check is the head palpable abdominally, and then I would do a vaginal examination to check for dilation, station, and fetal position, as well as caput and moulding. From there, I decide where the best place to do this delivery is, whether it be in the room or should it be a trial of instrumental in theatre. And I would tell the midwife to alert the senior doctors that I was going to do an instrumental delivery in the room. So then, depending on, as I said, my findings, I would either do and I'd also, while I was examining, I would ask the mother to push so that I would feel is there descent with maternal effort, and then based on these findings in terms of how much caput, if the head is if the position is direct or not, and if the maternal effort is appropriate, I would decide on forceps or kiwi delivery, and also I would ensure that the patient had adequate analgesia before I proceed with the kiwi delivery or the forceps delivery. I would empty the maternal bladder. I can see here that a forceps would use, so I would do a ghost application of forceps, and then I would apply the forceps, lock them with these, and deliver the baby hopefully within 3 contractions. And I would also want pediatrics present in the room. So then I can see with the third pull of the forceps, the baby's head is delivered, but the shoulders are stuck. How would you proceed? So I would recognise that this is an obstetric emergency shoulder dystocia. So I would announce shoulder dystocia. I would call for help. I would lower the ends of the bed. I would lower the back. I would lie the lady flat. I would tell her to stop pushing. I would turn off oxytocin. I would break the ends of the bed so that the lady's bottom was at the ends of the bed. I would, since I call for help, I would want senior midwife, consultant obstetrician, neonatal team, and all present. So I would want 2 midwives on either side to bring the lady's hips, to her abdomen, which is called Mac-Roberts position, and I would try and deliver the head with routine axial traction. If that wasn't successful, then I would tell the midwife which side the fetal back is facing, and I would ask for suprapubic pressure. With that stage again, I would try to deliver with routine axial traction. If that didn't work, then I would try to either deliver the posterior arm or else begin internal rotational maneuvers, depending on whichever is easier once I insert my hand into the sacral fossa. And as I said, depending on whichever is easier, and try to deliver the head again. If I deliver the posterior arm and if the head still wasn't delivering, then I could rotate the baby in 180 degrees to try to swap the posterior arm for the anterior arm, which deliver the baby, or else vice versa by doing the internal rotation maneuvers, which is either putting pressure on the posterior aspect of the posterior shoulder or the anterior aspect of the anterior shoulder. Try to deliver the baby that way. And if that didn't work, I could roll the mother onto all fours and try the procedures again. Of course, I would be aware that the fetal pH is going to decrease by 0.04 per minute, and I would have in the back of my head that the last case scenarios would be deliberate fracture of the clavicle, Zavanelli maneuver, or a symphydiosity. However, I'd be aware that these are very unlikely ever performed in the developed world. And then, of course, I would be aware that this is traumatic for the mother. I would have a scribe here because it's an emergency. I'd be communicating with my team via ISVAR, and I'd also be continuously talking to the mother, reassuring the mother and reassuring the partner. And would note to make very good debrief to both of them afterwards and to the team. So then following delivery, Miss Seiki has a postpartum hemorrhage we have received blood. Half an hour later, the bleeding has been controlled. The midwife called you in because Mrs. Seiki is distressed and with fever, chills and discomfort with wheezing. So my management would be, I would tell them to stop the blood. I would examine the patient, so I would ask for her history, how is she feeling, ask a little more about the chest discomfort. Is it just with breathing in, so is it pleuritic or is it there all the time? Could she describe it to me? And is she feeling short of breath? Has this ever happened to her before? I would examine the patient, so I would listen to the patient's chest, listen to the patient's heart, have vital signs done, and then check the fever. I guess my number one differential diagnosis will be a reaction to the blood. So as I said, I would stop the blood. I would check that the patient received the right blood in terms of, is this cross-matched appropriately for the patient? Was it the correct blood? I would ask for senior anaesthetics to come immediately. I would send bloods as FEC, blood culture to the patient's parexic, CRP, UNE. I would call the blood bank to inform them. I would give the patient, you could consider the patient Piriton and IV hydrocortisone. And if this did turn out to be a reaction to blood products, then I would inform the lab so that they could deal with that blood product, but also write a clinical incident form. Okay, I can go on to the next station if you like. On to the next bit of it.
Yeah, I'd like to ask you one question if you don't mind. What is the chance that she will have another episode of this shoulder dystocia next pregnancy? Risk of recurrence here.
Dr. Aisha, do you want me to answer the last question? I just missed the last bit.
Yeah, sorry. That was 1 in 16 to 1 in 25, right?
I thought it was so if you scroll up for a second.
Yeah, that is fine. Okay. So we can go to the next station, station 4.
Okay. So just how I would have said for the last for the brachial plexus is that so there's 10% chance of shoulder dystocia recurring again. Also, she'd have an increased chance of PPH in the next pregnancy. So I tell her that, of course, we could discuss. So in terms of the brachial plexus injury, I'd reassure her that the pediatricians will see her that it's either going to be. I discussed her the different types, so upper herbs, lower clumps, or total. I tell her that they often will do imaging such as an MRI to look at it, that the baby will get physio, and reassure her that in most cases, so they recover quite well. And then just in terms of course, I tell her about the increased risk of shoulder surgery in the next pregnancy and just what we can do to prevent postpartum hemorrhage, such as IV cannula,
Yes.
and oxytocin infusion. And I debrief the patient well, and I debrief the partner well, and I bring them both back in 6 weeks for a debrief with the consultant as well.
Yeah, thank you very much for repeating. Actually, you know why I have asked you again? Because they want to be very specific about the numbers. And then why? Because we have managed this problem this time, but maybe next time she will have this problem again. So it will help us. She should remember this and she should not forget in her next antenatal care. Okay, that is the point. Thank you. So let's go to the station number 4. Here it is.
Okay, so I will begin by introducing myself and confirming the name and date of birth of the patient. Then I would ask her to, so I'd confirm that she's an 80-year-old lady. I'd ask, does she have any children, and does she have any pregnancies? And then I'd ask when she went through menopause, and then I'd ask her to tell me a little bit about why her GP referred her here. So I'd ask how long the cyst has been going on for, what has she tried for it so far, has she noticed any bleeding or any abnormal discharge, and then I'd ask, were her smear tests always normal in the past, does she have any other medical problems at all? In Does she go to the doctor for any other reason? Any diabetes, high blood pressure, asthma? Does she have any other surgery before? Ever had any allergies to any medicines? Does she take any regular medicines? Does she smoke? Does she drink alcohol? Who does she live with? Does she have good support at home? Is she still sexually active? And then in terms of review of symptoms, does she notice any weight loss, any loss of appetite, feeling tired? What investigations would I like to perform? So first of all, I examine the patient, so I take the vital signs, look at the BMI of the patient, look at the general health, general well-being of the patient, and I do an abdominal examination, feeling for any masses. I would look at the vulva itself. My differential for this would be VAN, vulval carcinoma, lichen sclerosis, or lichen planus. So I'd look at the patient in this way. Then I'd also look at the vagina and at the cervix as well, and look at the anus. And so then, what investigations I perform, I would do an incisional biopsy of the lesion, and I try to include some normal skin as well as some of the affected skin, so I could see, so that the histologist could see the difference. And then I would bring her back at this stage. So then the biopsy showed it was SCC. So at this stage, then I would perform a CT scan and an MRI scan. The MRI scan to look at how large the lesion is, and the CT scan to look for any nodal involvement or any metastases. So what's the most appropriate management? So it depends again on the stage of the carcinoma. So it's good that there is no node involvement. If it was early stage cancer, I could do a wide local excision, and if it was and depending on the stage of the cancer, do either a unilateral or bilateral, or could or a sentinel node biopsy of the, so unilateral or bilateral lymphadenectomy, or else sentinel node biopsy. And again, that will be depending on the stage of the lesion. Or else, if it was a more advanced cancer, you might have to think about doing a radical vulvectomy with bilateral lymphadenectomy. And she might need ongoing radiotherapy as well. So you referred Miss Beecher, gynecologist, wants to know why. What will I do next and the risk involved? Okay, so I would bring Mrs. B into a quiet room. I'd ask her would she like anyone else there. I'd ensure that I've given away my pager, that I've gone through her notes very well, and that I have time. I'd offer her tissues or a glass of water if she'd like it. I'd talk to her first of all, talk about what led us up to this point, the fact that she had the vulval itch. I took the biopsy and I asked for the other scans, and I'd ask what does she know so far and what does she think is going on. Then at that point, I tell her that unfortunately the results of the biopsy weren't what I hoped for, and is it okay if I continue? So then I tell her that unfortunately this has shown that she has vulval cancer. I tell her that the scans showed that there wasn't any enlargement to the groin yet, which is a very important in vulval cancer. I tell her that I'm really sorry because I know that this is not what she wanted to hear, but that what I'm going to do next is make a good plan for her so that we manage her in the best possible way. I tell her that I'm going to organise some further scans for her, that I'm going to link her in with a cancer centre who are the specialists in managing cancer, and I'm going to link her in with the oncology liaison nurse and also with the MGT. I explained that an MGT is a multidisciplinary team where there's groups of experts come together, such as physiotherapists, occupational therapists, nurses, oncology doctors, and gynae doctors, to best plan her management for her and best plan her treatment for her. I'll explain that the next what they know the treatment will likely involve, then ordering further scans, which of course I'll talk to her about then, and then removing the lesion, and that will be by a surgery called a vulvectomy, where they remove the vulva, and that sometimes they remove the nodes as well, and that what the risks are with that is that there's risks of wound infection or wound breakdown afterwards, but that you'll be very well linked in with a tissue viability nurse, and that there's risks of leg swelling, there's risks of infection, recurrence of the cancer, or need for further treatment such as radiotherapy. Then I'd ask if she have any more questions at all. I would give her a patient information leaflet, link her in with support teams, link her in with counselling if she needs to, arrange an appointment to come back and see me as well as the oncologist, and ask her, did she have any further questions? Can she explain it to me as if she was explaining it to someone at home, that I could understand that she did understand everything? And then I tell her, look, the strategy is that we're going to order you more tests, link you in with all the best experts to get you the best possible chance of treating this disease.
Yes, that's great. So in lichen sclerosis, they can ask on this question on a background of lichen sclerosis or lichen planus, and then, or they can also show you the slides and they can ask you that what condition she has. But they will ask you simple questions. What would be the most common presentation? How you are going to treat it, and if she has this itching, and what treatments you can give, and what are the first line treatments, what are the second line treatments, but the things you will be knowing about them. Okay, don't worry about them. Let's go to the next station. Once you are done, then I'll take you to the next page.
Yeah. Okay.
These are the tasks here.
Okay. Okay. So, so just specifically, what are the results of the tests? So I would explain to Mrs. B that the results of the tests show that she has a condition known as polycystic ovary syndrome, that this would explain why her periods were being so irregular, and also the fact that she's noticed the increased hair growth. I tell her that how we test for this, how we know this condition is to do with biochemicals, so blood tests such as increased testosterone, through the periods being irregular, and also by the ultrasound appearance of follicles in the ovary. I'd assure her that it's a very common condition, um, and that we have a lot of women living with this every day. And so, and what it is that there's an excess amount of follicles in the ovaries, but it's linked to increased testosterone in the body, and also increased estrogen in the body. That in terms of the risks of polycystic ovary syndrome, that some people can find it harder to conceive. So I want to know specifically if she's looking to conceive at the moment, and I tell her that's because you don't ovulate quite as often as people without the condition, and that when the time comes to conceive, that we can help you with that through optimizing your BMI and also considering ovulation induction. I tell her that it is also associated with increased risk of endometrial cancer, but that we can reduce that risk significantly by inducing a withdrawal bleed for her every 3 months. So we'll do that by giving her progestins at least 3 a year, and they're just oral tablets that she can take, or else we can put her on the pill, and that will do the same job. If she's not looking to have a baby at the moment, I would also tell her that, look, there is increased risk of diabetes. I can see from your fasting sugar that you don't have that at the moment, but we should check this every year, and that there's also an increased risk of problems with your heart. So, um, and by problems with your heart, what I mean by is increased risk of cholesterol, increased risk of heart disease, which can lead to things like heart attack in the future. And I can see that her um LDL cholesterol is a little bit on the higher side at the moment. So I tell her just to eat a very healthy diet, and encourage lots of exercise. So is there anything that can be done to reduce the hair? I tell her that there is, and that there are very good creams that can be used, such as Viniqua, or else that she can get laser with the hair, and that works very, very well. And then it depends if there are any other treatments necessary for my condition. So the first is going to be lifestyle management. So I'd advise her to have a very healthy diet and regular exercise to maintain a healthy BMI. And then also and that will help reduce the chance of heart disease. It'll help reduce the chance of diabetes, and it'll also increase her spontaneous ovulation, which will help her have a child when the time comes for that. In terms of preventing her risk of womb cancer, I would recommend that we induce a bleed 3 times a year. And the reason we do this is to thin the lining womb, and we use progestins, or else we can commence you on the oral contraceptive pill. I tell her that, cosmetically, that in terms of the excess hair, that of course she can have laser, or she can use the Viniqua cream. And I tell her that when it becomes time to her wanting to have a child, that have regular intercourse, because people do often conceive with PCOS, but that if she is having any trouble, then to contact a gynecologist, because we can do a special test to make sure that she is ovulating, such as mid-luteal phase progesterone levels. And then I'd ask, does she have any other questions? I would reassure her that this is a lifelong condition, but that there is a lot that we can do for this. And I would give her a patient information leaflet, and I'd link her into support teams, and I'd bring her back again to think about everything that we discussed and talk about it again. And of course, I actually forgot to mention that that if she is becoming insulin resistant, that we could also consider stop, which she isn't at the moment, but we could start her on metformin later on as well. and that we'll do an oral glucose tolerance test and cardiovascular risk assessment annually from now on. And I'll also write to her GP so her GP's aware.
That would be great. Here is our next station.
Okay.
Yeah, have you noticed this blood draw?
Yeah.
That's good. That's good. Next page.
Okay, so I begin by introducing myself, and so first of all, the antenatal history. So begin by introducing myself and introduce myself to Miss Bertram. I would ask Miss Bertram what age she is, what number of pregnancy this is, what her gestational age is, so how far along she is, and I would ask her how her pregnancy has been for her so far. I'd want to know what type of IVF this was. Was it IVF? Was it ICSI? What is it, donor eggs? Is it her own eggs? Was it double or single embryo transfer? Then how has her pregnancy been so far? Has she had any bleeding, any vomiting? Has everything been well? Does she have any medical? And then if she had any other pregnancies, what was the outcome of those pregnancies? Any complications? Were they spontaneous or IVF as well? I'd want to know in terms of medical history why she had IVF. Was it maternal? Was it female factor or male factor or mixed or unknown? What investigations did she have for it? Does she have any medical problems, specifically high blood pressure, diabetes, renal problems? Then in terms of, are her smear tests normal? Has she ever had surgery? Does she take any? Is she allergic to medicine? Does she take any medicine? So I want to know, was she taking folic acid? And then is she on aspirin? Is she on progesterone support for the IVF? Then does she smoke? Does she take alcohol in pregnancy? What does she do for a living? Does she have good support at home? And then does she have any family history? And I guess specifically family history, does she have any family history of blood clots, of diabetes, or of preeclampsia? I would tell her that there are increased risks in this pregnancy with it being twins, that it's very important that we check the chorionicity, and I'll explain to her that, how many placentas, and the amnionicity, which is how many amniotic sacs, as soon as possible. So that's ideally done before 14 weeks, and that will help plan the care for this pregnancy. I'll tell her that it's going to be seen in a high-risk clinic, and ideally in a special twins clinic, that if it's monochorionic twins, that we'll see them every 2 weeks from 16 weeks, and aim for delivery at 37 weeks, and if it's dichorionic twins, we'll see them every 4 weeks from 26 weeks, and that we're aiming for delivery at about 38 weeks. I would inform her of the risks of the increased risk of multiple pregnancies include increased risk of fetal growth restriction, of preterm birth, of preeclampsia, of gestational diabetes. So that will also be screening her for gestational diabetes at 28 weeks, and if she had NCD twins, I talked to her a bit about twin transfusion syndrome, and I talked to her about fetal growth disorders. So then, and of course, I'd also tell her that there is an increased risk of chromosomal abnormalities in twins as well. And so then she went on and she got her screening tests, and I talked to her results that first of all, that the screening test showed that there is that at first I explained to her this is a screening test, so it's not a diagnostic test. It just shows that there could be an increased risk of a chance of a baby having a condition. And I talked to her a little bit about, you know, that she had this done, why she had it done, that there is increased risks of this with twins. And I'd ask, is she happy for me to talk about the results of the screening test? Would she like anyone else with her? And I tell her that, you know, in twin 2 that there's increased thickness of the back of the neck, and that's something called increased nipple thickness, and sometimes that can be seen in a babies with Down syndrome. And that also her blood test that she had does show that there is a small increased risk that one or both of the twins might have Down syndrome. I tell her that of course this is just a screening test, so it's not definite, and I would ask her would she like that I tell her of her options, that her options are either to go on and have an invasive diagnostic test to see for definite, to look at the karyotypes, which are the chromosomal makeup of babies, to see if they are Down syndrome or not, and or else if she doesn't want to do that, that's absolutely fine. We can just continue to monitor the twins and in the anatomy scan do a very detailed scan to look at this at any other soft markers for Down syndrome. And I'd ask, would you like me to talk more about invasive diagnostic testing at the moment, or would you like to come back again with her partner and give her information leaflet? If she was open to talking about it, I tell her that there's 2 types that we can do. The first is chorionic sampling, and that's done from 10 to 13 weeks, and the second is amniotic amniocentesis, and that's done ideally from 15 weeks on, but can be done from 14 weeks on. And I'd explain what they are, that chorionic sampling is aspirating small pieces of placenta for karyotype, and that amniocentesis is aspirating a small bit of the amniotic fluid for karyotype. And I tell her about the risk of miscarriage is about 1% for both. And of course, because she's rhesus negative, I'd explain that we would give her rhesus negative is and explain about anti-D antibodies, and I would tell her that there is a chance that some of the baby's blood can pass into your circulation system in this procedure. So in order to prevent and that if that happens, then if this baby is rhesus positive, then they can cause antibodies to develop in your system, which could harm a new pregnancy. So in that case, if you do decide to go on to the chorionic sampling or the amniocentesis, that we will give you anti-D afterwards, and that, you know, as well as that, if you ever bang your abdomen, if any trauma come into us or any bleeding, because we'll give you anti-D, and also at 28 weeks we will give you anti-D, and that's to protect against future pregnancy. So then, and like, of course, then if she decided to have the invasive testing, I tell her the complications of it. I tell her especially the 1% risk of miscarriage, and the risk of failure, and tell her that she can only get her results in about 2 weeks, and then I'd give her a patient information leaflet and bring her back in. So the results show that there is trying in 22 and normal in 20. Okay, so what do we do now? So I would tell her about her options and say that the first thing that we could do is do nothing, and, you know, I would assure her that, you know, this is a very personal choice, and that it's a personal choice for herself and her partner and what's best for their family, that there's no right or wrong way to answer this, and that whatever she decides, we'll be there to support her the whole way. I'll tell her that I'm not going to influence her decision at all, but I'm going to just give her the best information so that she can make up her own choice, whatever is appropriate for her. I'll tell her that her choice would either be selective reduction of the baby or else continuing on the pregnancy. And I would go on to tell her the results, to tell her that, but I'd inform her that if she does want selective reduction, unfortunately that is done in England at the moment, just so that she'd be aware of that. But I'd give her all the leaflets and all the information so that she can make her best choice. I would link her in with perinatal counselling, and I would arrange a follow-up appointment for her to answer any questions she had and arrange a follow-up appointment, because of course it's unlikely she'd be able to make such a decision at the time, and I might arrange for her to meet with neonates as well for them to talk to her about what Down syndrome is, what Down syndrome is, what conditions are, how the baby will be affected, and what the care for Down syndrome baby will be like, so that she can make her own informed decision about what she'd like to do.
Yeah, you have to give them a chance to go over, think appropriately, and then we will convey their message to us. That's what they want us to do. Okay, regarding skills, they can ask you about several items. So here is first thing. So what do you see here?
So this is the paragraph.
Okay, so why we should use it?
So we use the paragraph to look at the progress in labour, so that it allows us to identify poor progress in labour and secondary arrest.
So can you tell me about this alert line? Yeah, please go on. I thought that you were strong.
So the first alert line, so that's the 2-hour action line, and
Okay.
that line is to alert us to the fact that this baby is making slow progress in labour, and that, for example, if an amniotomy hasn't been done, we consider an amniotomy, or if oxytocin infusion hasn't been started, that we consider starting oxytocin infusion, and to reassess again in 2 hours.
Okay. That's great. Let's go to the next slide.
So this is a picture demonstrating ultrasound guided fetal blood sampling. So this could be done, for example, in a baby with rhesus isoimmunization, to look at to check the fetal hemoglobin. Would be one indication. Or else you could do it in twin transfusion syndrome as well, to check the fetal hemoglobin.
So is there any non-invasive method of testing it?
You could look
Mhm.
at the middle cerebral artery,
Yeah. Peak
yeah,
systolic velocities. Yeah.
yeah. And if the MOM is over 1.5, then that would also indicate fetal anemia.
How the weeks of pregnancy, the gestation period will affect your decision to deliver or to offer in utero transfusion.
Well, I guess you're looking at fetal viability. So it would depend on gestational age. So of course we know that the age of viability is 24 weeks, but the chance of best survival will be over 28 weeks. And as well, you'd look at the level of anemia, and is there any associated features such as hydrops, and you'd make your decision then based on those factors together with the fetal medicine specialist.
So please look at these lab results. I'm sorry if they are not very clear. So can you read them?
Yeah.
Okay.
So this lab result is showing hypoalbuminemia with elevated transaminases and elevated alkaline phosphatase. But of course, you'd expect low albumin and high alk phos in pregnancy, but there are elevated transaminases. So my differential in pregnancy, you can get elevated transaminases from obstetric cholestasis, acute fatty liver in pregnancy, or HELLP syndrome.
Okay. So this way, if this patient has complaint of severe intractable itching in the palms and soles, how you will manage her?
So then you would like to do a bile acid as well, and you'd be thinking that this is obstetric cholestasis. How you'd manage it would be, you would inform that there is an increased risk of poor perinatal outcomes, such as a small increased chance of stillbirth, increased chance of preterm labour, meconium staining, or fetal distress. I would check her LFTs every week and bile acids every week. I would start her on Puritan, give her emollients such as menthol, such as aqueous solution or menthol. I could consider giving cholestyramine. In the past, ursodeoxycholic acid was used because they felt that it reduced the function tests, but there was a paper published in The Lancet in 2019, and that was a landmark paper that showed that ursodeoxycholic acid doesn't improve perinatal or maternal outcomes. So for that reason, it's now stopped. It's not used anymore. And in terms of, we normally offer early induction of labour, and we base that off the level of bile acids. So you consider induction from 37 weeks on, or if the bile acids are over 40.
Yeah. So what is the chance of recurrence?
40 to 90%.
Yes, that's great. So this is a second result, lab result. So what do you think your patient is having? These numbers have been taken from some RCT, and does it make any sense that these findings were significant or insignificant?
Would you mind? Oh, sorry, that's actually me. So sorry.
Yeah, yeah.
No, sorry, I was talking to myself. Okay, so in terms of significance or insignificance, so if the p-value is less than 0.05, that's normally taken as significant. So in that case, the significant value would be that more men had positive herpes surface antigen was reached statistical significance, and that more men had positive Hep B core antigen reached statistical significance, and the last two results did not reach statistical significance.
Yeah. So these two results, first and second one, they were significant and others were insignificant.
Yeah.
So, okay. So here I have another set of lab values. So if you look at these values, what do they tell you? This is someone who had some abnormal presentation, and then these tests were done on her. So here we have this prothrombin time here.
So the prothrombin time and the thrombin time are both significantly increased. So there's increased bleeding time. So that would make me think of a coagulation disorder. So I would want to look further into that and take the patient's history. But a differential diagnosis might be, for example, von Willebrand syndrome, or else in the acute setting, disseminated intravascular coagulopathy.
Okay. So if we look at these two sensitivities,
Yeah,
both are like 90% sensitive.
yeah.
So what does it, how you would interpret 90% sensitivity?
So sensitivity is looking at how likely something is to pick up a condition. So so if the condition is there, how likely it is that it would pick it up. So 90% would say that it would pick up 9 out of 10 cases.
Yes, that's great. If you are going to screen a population, which test you would like to select? The one with higher sensitivity or with higher specificity
Higher specificity.
for screening?
For screening, ideally you'd like it to be both.
Okay. And if you have to go for confirmation, you have screened a population and now you want to confirm the findings. So you would like to choose the test with higher sensitivity or specificity. no problem. Sometimes they can ask you. So if you are screening a population, select the test with higher sensitivity. And if you are just going for the confirmation, choose one with a higher specificity. Okay, that is the recommended. Very unlikely, but sometimes they can ask you to interpret the results also. Barely, but still. Okay, let's go to this one. What do you see here? And
So
for confirmation and specificity, yeah.
thank you so much.
So what do we have here?
So this is face presentation. It is and it is
Mental interior or posterior?
so mento posterior, so you can't deliver it. So the baby's gonna have to have a cesarean section.
Yeah, that is what I said. Okay, thank you very much. Actually, they asked about face presentation, and I don't know why people couldn't tell them. And there was a lot of cry that they have asked about face presentation. Yeah, face presentation can occur. The incidence is 1 in 1500. And you can, if they show you mento anterior, yes, it can deliver. Sometimes they will ask you that if the baby is presenting by face, and you can feel his fingers on one side of the forehead, what will you like to do? Nothing, just wait. People will tell you like pinch it, or then the baby will just withdraw the hand, but you don't have to do anything. Just let the things proceed, and then we will do reassessment. Okay, thank you. Let's go to the next station. This is our station. Station number 8.
Okay, so what would I like to know about her in the pre-op word round? I would like to know, first of all, her age, if she have any children, what were her deliveries, were they vaginal deliveries or not? Why is she having a vaginal hysterectomy? Is it prolapse? Is it head bleeding? What's the reason? Sorry, not head bleeding. So then, what's the reason? Has she consented to the procedure? Does she have any medical problems? Has she been seen in the anaesthetic clinic beforehand? Does she have any other surgeries before? So I want to know, is there any scar tissue? Is she allergic to medicines? Does she take any regular medicines like antihypertensives or blood thinners, for example? I would want to know, does she smoke? What does she do for a living? Does she have good family support at home? Is she sexually active? I would want to know, does she have any blood? Does she have any bloods done? Do we know her hemoglobin level? Has she had a group and save sent? Does she have a baseline urine and liver function test? Has she had an ECG? And then talking to the lady herself, I'd ask her, is she feeling fit and well today? Does she have any recent illnesses? And then, does she have any questions for me about the procedure? Does she understand why she's having the procedure? She signed the consent form. She's seen the anaesthetist. Is there anything that she hasn't been sure for me, or anything that she wants to run through with me? And then I'd ensure, as I said, that the consent form is checked and that her relevant bloods are done. So the steps of the vaginal hysterectomy. So I guess first of all, I would bring the lady into the room. She would be introduced to the anaesthetist. We would perform the WHO sign-in. So we would confirm the names of the team, confirm the operation, confirm the patient's name, and confirm any anticipated risks with the patient. And of course, in the pre-op ward, I'd also want to know the lady's BMI. So then the lady will be anaesthetized. So this is usually with general anesthetic for a vaginal hysterectomy. We would do so then I would drape and paint the patient, and the patient would be positioned in the lithotomy position. I would drape and paint the patient, and then I would perform a vaginal examination, and I would perform a manual examination to feel the size of the womb, and then I would insert a speculum and insert a tenaculum and look for descent to the womb, and also feel the uterus sacros to ensure that the lady was suitable for vaginal hysterectomy. So then I would insert local anesthetic or adrenaline into the cervix, and the reason I do this is to reduce blood loss and also to identify the planes of the tissue. Then I would make a circumferential incision at the cervical vaginal junction. I would reflect the bladder using either blunt or sharp dissection. I would enter the posterior peritoneum and clamp, cut and tie the uterosacral ligaments plus minus the cardinal ligaments. I would enter the anterior peritoneum and clamp, cut and tie the uterine vessels within the broad ligament plus minus the cardinal ligament. At this stage, then I would deliver the fundus into the vagina, and I would clamp, cut and tie the ovary. Well, what I should have done earlier in the pre-op stage was confirm that are we retaining the ovaries or removing the ovaries. But if we were retaining the ovaries, I would clamp, cut and tie the ovarian ligament, and if we were removing the ovaries, I would clamp, cut and tie the IP ligament, the infundibulor pelvic ligament. Then at that stage, I would close the vaginal vault. So I would do that either with continuous, interrupted, or purse string suture, and then I would, and while doing that, I'd incorporate the peritoneum to give vault support, and then I'd usually finish by performing a cholecystoplasty. So the reason I do this is to prevent vault prolapse, and I would incorporate the vaginal peritoneum, uterosacral ligaments, and vaginal wall to obliterate the posterior cul-de-sac, and therefore give the vault greater strength. And if this operation was for prolapse, then I would have consented the woman pre-operatively for plus minus a sacrospinous fixation, and I would do that. And when I would do a sacrospinous fixation is if the vaginal vault was able to come to the level of the introitus with traction. Then I would insert a catheter. Some people insert a gauze, others pack, others don't, and I would give good analgesia, and I would visit the lady pre-operatively, and I would have asked for the urinary catheter to be out once the lady is mobilizing. I would ensure good multimodal analgesia, ensure early mobilization, TED stockings plus minus low molecular heparin, and I would ask the lady to come back and see me again in 6 weeks.
Thank you.
Thank you. Okay, so the first thing I would do with this condition is carry out an audit to find out why this happened. So I would collect data, and so I would first of all pick an auditable standard of what the number of UTIs should be. Then I would collect data to find out how we're doing against this measurable standard. Then I would implement changes if necessary, and then I would re-audit the condition. And specifically for UTI, what I would do is I would look over the cases, look to see what happened and what's changed. And then in terms of preventing urinary tract infections, I would ask for prophylactic antibiotics to be used pre-operatively when warranted. I would ask for urinary catheters only to be inserted if needed and to be removed as soon as the patient is mobilizing. And I would talk to the staff about good surgical hygiene and good draping and painting before the operation, and I could look at maybe doing an audit about cleansing the patient again after the operation, and also talking to the patient about good urinary hygiene after the operation. And also I could after the audit I would dissipate the results to the staff by holding meetings, by putting up posters, and by having teaching information, so that I would let everyone know the results of my audit.
Okay, thank you very much. Thank you very much. So what is your opinion about the long thickness?